Yeah, it's a pleasure to see everybody today. I was saying how from the podium here yesterday, I was looking out, and you know how in a meeting you go to and a lot of people are like on their phones and stuff? Everybody yesterday, every talk was like there. It was like, this is a pretty engaged group. It's pretty neat. So I'm, a couple seconds about background. I actually did my PhD in physiology and endocrine stuff first, and then I decided I like people better than rats, so I went into medicine. But decided I really did like endocrinology a lot, which what brought me into the field. Started doing gender-affirming care probably like 9 years into my career, so that's like 2005. So now 17 years for me, really interesting watching everything evolve over that time. Being privileged to work with a bunch of people. My medical record would say somewhere in the 2000s, I guess, for people for gender-affirming care. And privileged to learn from them. And it's the kind of medicine I like because it makes sense. It's cool because it's science and endocrinology, and it's really fun because just about everybody gets happier. I mean, what else could you want? So I think that probably brings a lot of us to the field. So just a reminder then about why I was there, and then in particular, and I should say he, him for pronouns for me, but also in particular, again, the big picture is this is just a little part of people's gender-affirming voyage, not for everybody. Not everybody wants it or needs it. It's really good to understand all the other things that are gender-affirming for people, which is what the whole Foundations course is about. So that's kind of where we fit, I think, in this. So the slides I'm going to say are prepared by WPATH. And let's see. No advancing here yet. I have no disclosures. This is my disclosure sign. I'd say that basically not only are the medications off-label, the whole field's off-label, right? But that's all good. And slides are prepared by WPATH, and my review of SOC8, because it came out, was like last night. You know, so I had to read through the hormone section. Some things have changed, and I'll probably have a chance to go in better detail for it. So we'll take next slide, please. So our objectives, and we'll keep paging, just talk about sex hormone physiology, which is feedback loops, dear to endocrinologists, next button. Talk both about masculinizing hormone regimens. I'll talk about adults, and Dan with adolescents, although obviously lots of overlaps, to look at the feminizing regimens. And next button. Talk a little bit about everyone's favorite time of life, puberty. Not only does we all get to do it once, some people get to do it twice. So we are all products of sex hormones. We're exposed to microscopic amounts in utero, and then we have surges of hormones later in life that lead to development of secondary sexual characteristics. If you think about hormones, they are in our blood, but they get in the blood because they're told to be in the blood by other hormones. So hormones, a chemical message, goes in the blood. Thank you very much. Some hormones are made out of proteins. They're called peptide hormones. So those ones come from the bottom of the brain called hypothalamus, tell the pituitary to release other hormones that are proteins with sugars attached, go down to gonads, testes or ovaries, and ask them to release their hormones or make sperm in some cases or eggs. Those hormones are sex hormones. They're sex steroids because their initial origin was out of cholesterol, of all things. So the idea of puberty is there are a number of surges that start up from the hypothalamus saying it's time, released in a pulsatile fashion. That's very important. It tells the cells in the pituitary gland called gonadotrophs to make their signals, follicle-stimulating hormone, luteinizing hormone, same for everybody. Those move down to target tissues, either ovaries or testes, and tell them to make their products. There's feedback of the products that are produced, estrogen or androgens, back to the top of the system saying, okay, I'm here. So just like the thermostat in your house. When something isn't, when you want more of something, thermostat tells the power production, let's turn up the heat. Up goes the heat. When it reaches a level, the sensor says, okay, I'm there. I can stop sending my message, things stop. So we are manipulating those issues when we are putting hormones in the blood, either from our gastrointestinal tract by pills or through our skin or under the skin by gels or injections. So this is the feminizing puberty. You can see the feedback loops from estrogen and progesterone, the two ovarian hormones. And in masculinizing puberty, again, pulsatile release of the signal from the bottom of the brain to the pituitary that makes the same two hormones as that come down, in this case, to testes, telling testicles to make both testosterone and sperm, and it's fed back. So we heard a little discussion yesterday about pubertal stages, development named by Dr. Tanner, and a discussion in particular about Tanner stage 2 in puberty as sort of the place where a lot of choices for interventions for hormones takes place in adolescence. So we'll come back and hear from Dan about that in a bit. So we're going to move on to testosterone-based therapy. I noticed a bit of a trend. You know how language changes so much? Locally, I noticed we're using less of the terminology masculinizing gender-affirming hormone therapy, as just calling it testosterone-based hormone therapy, gender-affirming hormone therapy, or estrogen blocker-based therapy. No right or wrong, but I'm always trying to be really acute to some of the nomenclature changes. So you keep an eye on that. It may or may not be a thing, but it just is a very factual sort of name of the hormones themselves. So the slides prepared here were called Absolute Basics of Masculinizing Hormone Therapy, and it's all about testosterone. I think testosterone is a great hormone. It just does what it's supposed to do. You know, it's like no fuss. It's got a bad rap. It's really good. There'd be nobody on earth without testosterone. It's just part of the deal. In the right levels, it does what it's supposed to do. It's like no fuss. Pretty straightforward. So they're quoting a range here, 300 to 1,000. So for the rest of the world who uses SI units, that's sort of in the 8 to 28 picomoles range. So there's lots of ways to get testosterone into the blood, but most ways do not involve pills. There's been discussions about pills having some harm for liver, so it tends to be under the skin or on the skin. Under the skin by injection. Injection, there's two common esters. Ester is a fatty acid molecule attached to the testosterone. So what that does when you put something under the skin, if you put it in something that's fatty, it stays there for a while, and it just gradually absorbs from that depot. So there's a couple of fatty acids and the liquid that help that occur. And those are the two common esters. And there's a dose range. It's probably pretty weight dependent for people. I would say really somewhere, but depending what people want, if you were looking for full androgenizing effects, somewhere pretty common to be in the 50 to 100 range, depending on size, if it's done weekly, or every 2 weeks at double that dose. But there are people who just want to move somewhere along the masculinizing spectrum who will use smaller doses. There's another ester called undecanoate. And that's a long-acting ester, which is available in lots of jurisdictions, but not in Canada, so I don't have any personal experience with that one for injections. There are a number of testosterone gels that are applied. In this picture, they're using one that's applied to the arm, but probably the commonest gels are applied to the abdominal wall or abdominal skin and just wiped off on the shoulder. And doses really in a similar sort of range, but it's daily because there's not so much absorption. Testosterone patches in Canada, those have just disappeared from the market. Have you still got patches where you're practicing? Hands up if you're still using patches. Yeah. I think they just weren't making enough money. They couldn't compete with the gels. It was a great product, but it's been a recent change for us. And there's different patches. And that's a daily patch. So, a little bit of a discussion. These are from a 2019 paper referring all these. They've just mentioned a unusual side effect for the undecanoate long-acting patch, which is oil embolism, which would be if you inject a big volume and got it in the wrong place, like into a vein instead of into muscle, it's possible to absorb it. Haven't seen it, haven't run into it, don't have any experience with that. Who would we, when we're doing interventions, it's always a good reflex to say, what's the worst thing that could happen? So these are it's called absolute contraindications to starting testosterone. Don't do it while pregnant because it's bad for fetuses. It's going to have hormonal effects that aren't part of the normal development at that time. Testosterone causes the bone marrow to make more red blood cells, and both in the gender-affirming literature and, frankly, in the cis-male hypogonadism literature, it's probably the commonest measure is just this hematocrit level. So we're trying to keep the hematocrit 55 or under, which was like the old speed limit for miles per hour. And I don't know about this. I think the idea here is that if you've got, I think we're really careful about starting anything in somebody who's psychiatrically unstable until coexistent mental health things are addressed. But this is not, the kind of doses that we use for gender-affirming care are physiological. It's not like roid rage where people who are anabolic steroid using bodybuilders are using like really high doses, like much, much, much higher. So I think that would be a bit of the discussion we could have about that. So I think that's the caveat I put on that comment. So time course. So some things come and some things can go away if testosterone is stopped. There's variable time periods, but a lot of things with testosterone happen very quickly. On this map, we heard yesterday about voice deepening, which can be, I think, probably one of the earliest things that I hear from many people, even with just starting doses from vocal cord changes. Hair is kind of a 6-month life cycle, so some hair things take a while to come. And once hair turns from really fine vellus to black terminal, it may not change. Lower growth, pretty common. Skin oiliness and acne, I'd say the people who really have trouble with this probably have a fair bit of baseline acne when they start, in my experience, but we do ask people to pay particular attention to their skin cleaning. Muscle mass and strength goes up pretty quickly. I would say it's not a common complaint to have vaginal atrophy complaints, but it certainly can be present, needs to be addressed. And there's variable effects on fat redistribution, and I think a scalp hair loss is pretty genetically programmed. So certainly for many people, this might include their desired effects. Not everybody has these effects, so it's all individual, and I'm always asking on day 0, what kind of changes you're hoping that testosterone use will make for you. And these would generally be felt to be undesired effects. Although, actually, a number of folks like a male pattern hairline if they're looking for more androgyny. So it really, again, can be dependent on the individual. And then it's good to have a kind of a discussion about time course of effects. So I thought this was kind of a nice graphic. It's the first time I'd seen it for these slides that I think is a little easier to understand than the purely tabular form. We certainly hand out a listed set of time courses for things, and this spells things out and go through them as we're consenting for testosterone use. We heard yesterday about just everybody to give thoughts for the best sexual history ever, the sort of 7 Ps here that were discussed, so that's reasonable. And I think the most important here that's focused on the testosterone again is that gender-affirming hormone use is not a guarantee of contraception. So if there's going to be sperm reaching oocytes and you don't want that, then you need to take other measures and do not rely on testosterone stopping menses and apparently stopping ovulation for that. So we're trying not to do harm. So it's funny, because a lot of these things sound pretty serious. I'm probably spending more time worrying about acne than anything, because a lot of these, if you're choosing your people right, the other things are pretty manageable. We talk about androgenic alopecia. We heard a little bit yesterday about lipid profiles, which are statistically significant and of uncertain, probably not very serious biologic significance in terms of outcomes in studies so far. There haven't been any signals that way. Pretty interested in if someone's hematocrit goes up, and the people that I'm particularly interested in are folks who are already have or are at risk for sleep apnea, because sleep apnea, because it drops your oxygen overnight, is another reason why you can have a high red blood cell count as a response to that hypoxemia. So it's an issue for some people with gender-affirming care. It's certainly an issue for a number of hypogonadal cisgender men who use testosterone and needs attention. So we heard yesterday that there are statistically significant effects on lipid profiles, which are outlined below. But the question is, do these relatively modest changes in lipids result in any increased cardiovascular disease? And to date, there's really not been a signal that that's the case for people receiving androgenizing, gender-affirming, or testosterone-based gender-affirming care. So the other issue, are we doing anything with respect to venous thromboembolism risk? And from that interesting Kaiser Permanente study from their database, no, there was no signal in that respect. So there are monitoring profiles that will be, and protocols that are in the new standards of care. These are the suggestions. On reviewing the text for things last night for both types of gender-affirming care, the sort of discussion was that the kind of expectation would, suggestion was that a lot of people would probably require, for the first year, monitoring at sort of 3-month intervals. But it's not, it says this is just a suggestion. There are other people who may not need that much if the situation is stable. So it isn't actually carved in stone. I guess that's a cliche that it has to be done every 3 months. But I think that's a pretty common aspect. And I think if you're in particular worried about some of the diabetes tests like A1C that take about 3 months to completely change, that's a bit of an intuitive interval as well. So you can see there's a number of different guidelines there with different ideas about what to monitor, so you may want to know what's present, but I think that going with the sort of WPATH recommendations of being sensible, which is like if you change something, you probably want to monitor it. A few months later makes sense. Monitoring fairly regularly until you're in a stable thing. Most folks are kind of really want to get on with being in a stable situation at whatever their target doses is, so you can usually move along pretty briskly. So you can see from these various guidelines, everybody's measuring the CBC for polycythemia. Most folks are having a look at the lipid panel. Testosterone is measured because there's sort of target ranges for it. Liver enzymes are tested. It's not that we're expecting injected or rubbed on testosterone to have too much effect on liver, but certainly from the oral literature it's worth looking at. Plus the prevalence of fatty liver is pretty high, which gives in all populations now can give some baseline lipid abnormalities. So this is a graphic of those labs. And you can see there, some folk, the minimalists are basically checking CBC and testosterone and deciding on case by case about the other things, both initially and subsequently. And in the commentary in SOC 8, they're saying once you get people stable, it's sort of 6 months or annually for most testing. So these are our target ranges for hematocrits. Testosterone, again, picomoles would be 8 to 28. And then a bit about timing, because it varies on a weekly injection schedule. So if you want to know peak levels, it's a couple days post-injection. If it's mid-cycle, it's about halfway through, which is on a weekly schedule, day 4, I would say, if day 1's first day of injection. Want a trough, it's basically on the morning of injection. They do vary somewhat, but the idea of a weekly schedule, hopefully, is it doesn't vary too much. I find people on every 2-week schedule, they notice it, because they've got a lot of testosterone in the beginning of the 2 weeks and a lot less at the end of the 2 weeks. So it's one of the advantages, I think, of self-injection is people can do it weekly. Transdermally, at least after, make sure they're a steady state, which takes about a week to get, and at least 2 hours after the application, because it surges in a little bit after application. Endocrine Society just had, in 2017, they just said midway between injections. I think that's mostly what I'm monitoring, and particularly in steady states. So baseline CBC, and then one can titrate doses up depending on circumstances. This was one suggested regimen of moving along fairly quickly. Can move to IM or sub-Q, we'll talk about in a bit. Kind of looking to get people in the target range, but again, ask people what their target range is. Some people want a little androgenization, just want a bit above cis-female range and below cis-male. And their approach here is to kind of move that thing along pretty briskly, pretty much monthly to what turned out to be this person's target dose. 100 milligrams is a pretty big dose, actually. I'd say most folks don't need that much for the sort of more slenderly built gentleman. So there's a number of resources for self-injection. Excuse me, in Vancouver, we tend to send a PDF of the Fenway version, a big, long PDF that's almost, it's very painstaking in every single step to do, what to buy, things like that, but people find that pretty helpful. Intramuscular is official, subcutaneous is off-label, but has been studied actually pretty extensively in gender-affirming reasons and works just as well intramuscularly and is easier. And when you think about it, people with insulin are doing like subcutaneous injections 4 times a day, and these are people doing a subcutaneous injection like once a week. Most of the instructions will say here's the kind of syringe to buy, and the smaller sort of insulin-type syringes are the desired ones. People can use pretty small needles for this. It's a fairly viscous solution and takes a while to go in. Turns out that's good news, because what hurts about injections isn't the needle going in, it's how fast you push the liquid in and distort the tissue. If you have a viscous solution, you can only push it slowly. Actually, it's a little more comfortable. Some folks will use a big gauge, that means a thick needle, to get the thick solution out and change to a little needle for injection. These are all little tricks. And then so just pause there a sec. I think some of the other tricks that people have, subcutaneous injections in the studies that were done, if you take your umbilicus, move out a couple of inches or 10 centimeters if you like, and a band about the same area, and the studies were done in that subcutaneous band there. It probably works almost anywhere. I'd say stay outside of the rectus muscle, that's the six-pack muscles, because they're close to the surface, and that you can still hit them, and it's a little more comfortable if you're just a little lateral to those. Okay. Moving on to estrogen plus or minus blocker-based therapy. The goal here is to change the sex hormone levels to bring male things down, female things up, or testosterone down, estradiol up. So usually looking for a cis-female testosterone range if people want full effects. And again, people may have varying ideas. Some people may want some testosterone, particularly for sexual function. And blockade can be achieved with medications that are designed for that. But just the use of estradiol itself will also drop testosterone. So estradiol use is a 2-for-1, more estrogen, and the brain says, ooh, sex hormone here if you're taking estrogen. I don't have to send out so many signals, and you make less testosterone. So from the New England Journal paper that Dr. Safer did in 2019, there's a list of different estrogen ways. Again, we say to get it in the blood, you can swallow it as a pill, put it in your mouth and get it through the skin, the lining of the mouth or under the tongue, called sublingual, using an official preparation or an unofficial one by crunching an oral pill. You can put it on the skin with a patch or gel, or you can put it under the skin with an injection. So the goal is get it in the blood one way or another, and there's a number of preparations for that. So we don't use estradiol if it's going to cause problems. So if someone's right in the middle of their deep venous thrombosis and pulmonary embolism, probably not the right moment to get started on estrogen. Some breast cancers, current breast cancers, are going to be estradiol sensitive, so you would not be starting in the middle of that process. This is the same generic comment saying if somebody is in a difficult psychiatric state, perhaps it's not the time to do it. I don't think estradiol is hurting their brain. I think this is a psychiatric comment, not a effective hormone comment. So we have reversible and irreversible effects. We'd expect, we can see on this list, we've got skin softening, diminishment of terminal hair growth, which is the black hairs, change in body contour, variable effects on fat redistribution. A lot of chest growth that can take place in glandular tissue can be irreversible. That happens in cisgender men with a condition called gynecomastia. There's a surprising number of adolescents have pubertal gynecomastia, just with a hormone surge, but a percentage of them will have permanent gynecomastia because the responsive glandular tissue kind of turns to fibrous scar tissue. It doesn't go away and needs to be addressed later in life through some other things. There are variable effects on reversibility of some of the other issues, including testicular volume, sperm production, and effects on erection. So depending, again, on the person, it may be desired for breast development, softer skin, slower growing hair, but again, I'd be having that conversation up front to see if those are indeed goals. There may be undesired effects. I would say most people's mood is like positive. It's like, yay, I started this. Make no assumptions about erection function, libido. Need to have just a clear discussion about what people's wants are there, and also the fact that people's wants about these things can change over time or with situations, and that we all have to remain flexible to that. So something to continue checking on as goal. This is the graphic here for speed. I think a lot of expectation management probably should be around breast growth, because lots of people want breasts, and breasts are tough. It's variable. Some people have very little growth. They're thin, not a lot of fat tissue, and there is a fair bit of fat tissue for breast growth. Some people are genetically programmed. It is a very feminine look, like the female triathlete look, but it's not always the look that people are looking for. And there's other people who are like stopping traffic. It's like lots of breasts, and so you can't tell, but at the end, it's just good that people understand, and that can take a few years to occur. Again, the fact that people are receiving estrogen blocker-based therapy does not mean they're not producing spermatozoa. And if their sperm could come in contact with someone's oocytes, they should know that's possible, and they need to be taking that as protection. So there is likely an increased risk of venous thromboembolism. We heard a bit about that in primary care talk yesterday. Again, from the big, really interesting Kaiser Permanente cohort, where they followed people with gender-affirming therapy, there was an increased signal for venous thromboembolism. And the longer people were receiving, particularly estrogen-based treatment, the higher that risk was. So the higher curves compared to reference cisgender men or reference cisgender women show that it's present. So it sounds kind of scary, but if you look at the absolute numbers, this is like everybody at all ages. You take everybody at all ages, I'd say that per 1,000 person years, it climbs from a background rate of about 1.1 event per 1,000 person years to about 5 per 1,000 person years of treatment. So if you want to be really quantitative with people, that's where you quote them. But again, that's taking people at all ages. And we do a lot of sort of risk management by discussing with people who may be at particular higher risk of venous thromboembolism and trying to use less risky forms of treatment. So there are not really no significant important effects on blood pressure or lipids. In fact, we saw a slight statistical downturn, but there hasn't been any important signal about that. It's really about venous thromboembolism. The monitoring regimens are also suggested at 3 months or after making changes, less so when stable. And you can see among different groups there are substantial differences in the analytes to be checked. This is a graphic of this, and they're particularly watching hormone levels, basal metabolic panel. I probably do more testing this. It's kind of embarrassing at the endocrinologist if you don't see diabetes or a lipid problem, so I'll be testing them anyways. So, but that's kind of the choice. We have target ranges of potassium in the reference range. There's a lot of, the idea on estradiol targeting from previous guidelines was to achieve mid-luteal estradiol ranges. The problem is there's a huge biologic variability in estradiol throughout the menstrual cycle, and even in the luteal phase, from people, between people. And you know, there's a lot of people who are young and healthy who are very interested in targeting supraphysiologic levels for maximum effect, so that's a discussion to consider. One of the ways you can tell you're doing well is testosterone's well suppressed. So the timing of blood work tends to be morning to get the morning trough level, injectable sort of halfway through cycles, transdermal, steady state after week, 2 hours after application. So we check potassium for people who might be affected by spironolactone. That's very few people. These are similar sort of ordinary sort of doses for starting. And most folks, and including the Kaiser Permanente study, we're probably on about 4 milligrams of estrogen daily in one format or another, tend to be estradiol. 100 milligrams of spironolactone, and this titration schedule, WPATH has pointed out here, a lot of folks would be on 4 to 6 milligrams of estradiol, 200 milligrams of spironolactone, and achieve a steady state. 6 milligrams is a not uncommon dose, but I think in the Kaiser study, most people were on 4. Just to give a feel for the kind of dose ranges, people who are changing over to intramuscular estradiol can move from an oral or sublingual form to injected, usually a weekly format. I'd say 10 milligrams would be of estradiol valerate's a pretty common weekly dose where I'm working. Questions about progesterone, lots of people have. The SOC8 actually had commissioned a systematic review to look at the question of progesterone in gender-affirming care, and there just weren't enough data to be able to form a conclusion. So their discussion is we don't have a lot of data to inform its use. The question about increased risk of cardiovascular disease is sort of extrapolated from Women's Health Initiative in postmenopausal cisgender women, which isn't really the proper comparison group. And they say, why don't you have a shared decision-making process? Their comment is not continued indefinitely. This is an area of clinical controversy and continues to be so with a lot of different practice. So I think I'd highlight that. Similarly, clinical controversy about alternate androgen receptor blockers. Biglutamides, most of our androgen receptor blockade knowledge comes from cisgender men prostate cancer literature. This is a second-generation androgen receptor blocker. In gender-affirming care, really no data in adults, one study in adolescents. Now, on this line that was on the slides, if you look in the SOC8, they just point out liver failure is like, it's really rare. And you know, there's extensive use of biglutamides in actually much frailer cisgender men with prostate cancer ages without this being a significant concern. So I'll just highlight that now from the slides as another area of clinical controversy about different kinds of androgen receptor blockade, but I think we'll have a chance to perhaps to discuss them there. At the moment, in the SOC8, they're just saying not recommended in feminizing regimens without further studies. Okay, so there's questions about where would we go with aging. There's just a section in the SOC8 saying we don't know. Lots of people like to continue their hormones well into life past ages when cisgender men keep making testosterone, and they keep making testosterone, they keep making testosterone. Levels go down a bit, but it's still there. Cisgender women stop making estradiol and progesterone at menopause, but a lot of folks who are looking for effects, and particularly bone-preserving effects, may wish to continue. So I'm conscious I've gone on at slightly auctioneer speed. I want to make sure we give ample time to Dr. Metzger for the adolescent gender-affirming hormone therapy. So we'll welcome Dan. Dan.
I will echo what Gail said about speaking after Mashall, because he's so suave and debonair, and then there's me. Like, the difference between adult endocrinologists and pediatric endocrinologists is that Mashall can show you 3 slides on puberty with feedback loops and stuff like that, and the pediatric endocrinologists have to sit in a room with teenagers and not, smack them. So, there we go. Much of what Mashall's talked about with hormone therapy would be the same thing we do for teenagers, except that teenagers are younger. There's lots of stuff going on. They're still, becoming adults. Their peers are still going through adolescence. And so a lot of what we do is similar, but at a much slower pace. And particularly now that we're treating kids even earlier, and I will mention that SOC8 talks about the age of 14, that obviously we need to start at much smaller doses because we don't want the kids to be ahead of their age peers as far as going through puberty. And adolescence is still, as you probably heard yesterday, as a time of transition. Kids are still figuring out their gender path. And so we don't want to be pushing them along with hormones faster than they really are ready to do that. The one big difference, I think, between pediatric endocrinology and adults on the adult side, as far as looking after trans youth and kids, is that we use puberty blockers, which aren't used as much, can be used in adults, but aren't used quite so much. So we may find, an 11-year-old assigned male, assigned female come to us who's just starting puberty, but who has already socially transitioned years before, has long identified as a trans youth or gender creative youth, and is growing unhappier and unhappier with the onset of puberty, the changes that they're having, which they do not want to have, which they've known they don't want to have, and which eventually may, require surgery or electrolysis to prevent. So pediatric endocrinologists have for a long time used puberty blockers in precocious puberty. So, when 2- and 3-year-old children go into puberty, we developed medications back in about 1985 that are puberty blockers. And so when we started treating trans youth, these immediately came to mind. Mashall has shown you very nicely that this whole GnRH pulsatile thing is what gets puberty started, and the pulses have to be like at a certain rate, so like so many per hour. But if you actually speed that up by giving a longer acting GnRH agonist, so a drug that acts like the pulsatile thing but just works much faster, it actually speeds puberty up over the first month or so, but then it can't keep up and it actually turns it off, which is just sort of not intuitive, but this is how puberty works. So that's how these drugs work, the puberty blockers, and they were designed specifically for this reason, but also for adults who have hormone-sensitive cancers, or endometriosis is another reason adults may take puberty blockers. But this basically just turns puberty off after about the first month. And so these are drugs that are used. We don't treat kids before Tanner 2. So Tanner 1 means no puberty. So kids are Tanner 1 from the time they're born until the time they go into puberty. Tanner 2 is the earliest changes of puberty. In assigned males, that means testicular enlargement. That's the first sign. In assigned females, it generally means breast development, the first sign of estrogenization. So because you probably learned yesterday from the speakers that we don't like have a blood test for who's trans, we don't have a really good way of knowing all of these things, it's always been thought that those kids who were gender creative as youth generally tend to declare themselves at the earliest or around the time that they start to have body changes of puberty. That's kind of like where, yeah, this is where that group of kids is heading, and some of the other gender creative youth, as Dr. Wong probably mentioned yesterday, head off on different paths. So once we have a kid who's clearly moving into increasing levels of dysphoria with their body changes, that's the earliest time we would do treatment with puberty blockers. And SOC8 says exactly the same thing. So this is really just a sort of a timeline of what happens as kids go through puberty, assigned males, assigned females, but we're really trying right there at the red mark to get things halted before breasts develop very far. A little bit of breast development will recede. We obviously don't want the kids to have deepened voices because that's a big trigger for dysphoria. We don't want the kids to get facial hair that they later on have to have, electrolyzed or something like that. So in a perfect world, if the kids were presenting that early, then we would be able to intervene that early. Not all kids present that early, of course, as you know, and some people present much later in life, but we're pediatric endocrinologists, so we see the kids. So one of the common sort of comments about all of this is that all of the research that has been done on this has been done by the Dutch people, like the early on research, and all of the trials that they did, God bless them, were very formalized. So they had a big group of kids, but back then, 1995-ish, they decided they would put kids on blockers at age 12. Many kids were quite a way through puberty at age 12, and they would start hormones at age 16. That's how they did things, which is great because somebody actually did a proper study back in the day when you could still do a study. Now, of course, you could never do a study by not treating half of trans youth and treating half of trans youth and seeing how that goes, because I think we all know how that would go. So, so a lot of the information that we have was kids, particularly the longer-term information that we have is on kids who were treated in 1995 who are now, well into adulthood, but they were all treated a particular way, but not the way we would treat kids now. And of course, now we're beyond the point where we can do proper, blinded studies and stuff like that. We have retrospective studies that we would have to look at. So one of the things you have to know in puberty is that for assigned males, the average age of puberty is 11 and a half, plus or minus 2 years, so that's 9 to 13 to get started. For assigned females, the average age is 10 in North America, plus or minus 2 years. That means 8 to 12 to get started. So we may be seeing 8-year-olds come to us with, gender creative, gender not atypical behavior, and this is a very early time to try to figure out, what are we going to do for the next, 8 years or 6 years until this kid's a little bit older. But that's just one of the things that we have to try to figure out is our level of comfort at treating some of these kids who present in puberty very, very early. Right. So there are a number of GnRH analogs. These are the puberty blockers. In North America, we tend to use leuprolide acetate, which is Lupron. Europe tends to use triptorelin, which is decapeptyl. We actually have that in Canada as well. It's called Trelstar. It's not. It's licensed for prostate cancer. It's not licensed for children, but it's exactly the same drug that's used in Europe for children. Neferilin is a nasal spray which has kind of gone out of fashion, and those of you who work in the US and maybe other places have an implant that's ridiculously expensive, and there's a Gaserelin, a Zoladex implant that's used in some countries as well. In Canada, we don't have the implant, and so pretty much everybody gets Lupron if they're going to use a puberty blocker. And these are given every 1 month. There is also a 3-month formulation, and we tend to start with the 1 monthly one and move to the 3-monthly one. But there have been shortages lately, so we give the kids what we can get. They're very expensive. Here, they're like $5,000 Canadian a year. In the United States, I know they're much, much more for exactly the same drug. There you go. Triptorelin is similar. So what do these analogs do? Well, they stop pubertal development. They slow down linear growth. So as you know, teenagers grow about twice as fast as prepubertal kids. So we slow down linear growth, but also the sort of bony changes that happen, the broadening of the hips in assigned females, the broadening of the shoulders in assigned males. It turns down libido. The parents don't seem to mind that. It turns down the teenage behavior. The parents definitely don't seem to mind that. So it does sort of just put kids in this kind of a holding pattern. That's good physically. That's not necessarily the best thing when all of your peers are going through puberty and your brain really isn't there anymore. It's kind of back in the, I'm a 10-year-old, I'm a 12-year-old, just kind of sitting there. There are some disadvantages there. It does decrease androgen-dependent hair growth. It decreases the deepening of the voice, the development of an Adam's apple, and it decreases testicular and penile growth. We'll come back to that. And in assigned females, it stops breast growth, and it prevents people getting their monthly bleeding. So what might the analogs do? I think there's now pretty good evidence that it provides relief to a great degree of gender dysphoria. The kids are like, okay, the breasts are no longer growing, or I'm not getting voice changes anymore. Now I can just like concentrate on my gender journey without having to deal with the physical changes that are happening. I think you know, when we started doing this, I met lots of adult trans folks who would just come up and give me a big hug, like, "Oh my God, if I'd known, you know, that there was something like you, someone like you, and when I'd started, this would have, you know, my life would have been so much easier, like, or cheaper, because I wouldn't have had to do all this surgery, electrolysis, or whatever." It does slow down the growth. We've talked about that, and sometimes the difference between kids not going through puberty and their peers becomes socially more difficult. And I think that for some of our trans youth, I think we see that they just don't get on with their life. They just kind of until they can go on hormones, but then at that point they're often a couple years behind their peers. There are some things that we have to let the kids know that they don't do. So in assigned males, it doesn't cause regression of any growth of the penis that's happened already, much growth of the beard that's happened already, or body hair. Once your voice has changed, it doesn't go backwards. Once your Adam's apple has grown, it doesn't go backwards. Once your shoulders have broadened, that doesn't go backwards, or your jaw has gotten bigger. Those are all, once you get that to that point, it doesn't go backwards. This is just a really nice example. These are identical twins. This is this is out there, so I didn't just take this picture. I don't even know these people, but these are identical twins, and the girl on the left was treated early in puberty, and this is her twin brother, who is not trans. Shows you the big difference that you can make when you start blockers early. What don't they do in assigned females? They don't cause regression of adult-sized breasts or hips. So whatever breast growth you have, unless it's just a small amount, just sort of 10 or 2, the breasts do not regress very much. The nipples do not change appearance or size very much. And whatever broadening of the hip bones that has happened already does not change. The fat on top and the muscle on top changes, but not the bones. There are a few side effects of the analogs that we need to know about. It's well understood. They're very safe. But we always have to talk to the kids about the first month that things are going to speed up. So the breast can start growing a little bit more, even faster than they were growing before. Or the genital changes in assigned males could happen a little bit faster than they thought. They might get more erections. We have to warn the kids, first month might be a bit rough, but for sure this stuff will work after a month. There is about a 5% risk of local reactions, which can sometimes be severe. So we've seen both in our trans population and our precocious puberty population, about 1 in 20 kids develops a local reaction that looks like an infection. So it looks like an abscess. It can be like pussy, require draining, very painful. Doesn't usually happen with the first injection, happens after the second, third, fourth one. that requires you to stop using this medication. You might be able to switch to a different long-acting drug. We were switching to the daily preparation for a while. That's now off the market here. But that's something that you have to warn folks about. If you're just about ready to get your first period, this can do it because it can drive your estrogen up and then it can drive your estrogen down, and that can set off. And of course, the very first patient I treated in 1998, that's exactly what happened. And we didn't really think about this back then, but the poor kid was out of town, had his first period, and just ended up in a bad place. So something that we have to warn the kids about. So one of the biggest issues is that if you think about, we haven't probably heard lots about surgery yet, but if you think about vaginoplasty, the creation of a vagina in an assigned male, you need tissue, genital tissue, to create that vagina. And if we are taking a 11-year-old boy who does not have a lot of genital tissue and blocking puberty right there, we're preventing the growth of the vagina for down the road, right? So we tend to, in assigned females, as soon as breasts start growing, if everybody's happy, that's when we would start. In the assigned males, we have taken more and more to letting things go for a little bit so that we get a little bit more genital growth, but then we have to stop generally before the kid's voice starts to change. And as Mashall mentioned, that's one of the first things that happens in male puberty. 3, 4, 6 months in, the voice starts to crack a little bit. We have to stop things there because none of the kids want a deepened voice. But we just talked about we're growing your vagina, and most of the kids can hang in there a little bit. Sometimes we just can't. We just have to stop the kids, and then it's up to the surgeons to figure out how to do that. And we know that this is not perfect. There's lots of stuff that obviously teenagers, their brains are changing, they're unwiring, they're rewiring. And if we've started one kid unwiring and half rewiring, and then we change their puberty the other way, and we're unwiring. So people have been trying to, the Dutch in particular, have been trying to figure out what this does for kids' brains. There's not been any really good evidence that we're doing anything terrible with their brain. But the things I think we kind of see how the kids are doing anyway. They're often super unhappy because they're in the wrong period, the puberty. Then they go out of puberty. Then they go back into puberty. And they seem to do reasonably the same as their friends, but we're not looking at their IQ and their learning ability and lots of other things. The other biggest problem with the GnRH analogs is that normally puberty is a time of putting the calcium into your piggy bank. So this is how we explain it to families. You've got a piggy bank for your calcium. You better get it all in by 25, because at 25, you're going to live off that piggy bank. And particularly if you're transfeminine, you're going to come off your estrogen someday, and you're going to be at higher risk for osteoporosis. So the puberty blockers slow that calcium accrual back into the bone quite a bit, back to the prepubertal level. And we do know that even if you look at people now at age 22, this is the Dutch folks and now other folks, even at age 22, if you've done all of this and you've gone off and then you go back on the hormones that you want to have, you have not caught up by age 22, which is about the time you need to fill up your piggy bank. So this is a concern that not everybody is getting their piggy bank completely filled up with calcium. And this is just a picture of how calcium works in assigned males. You peak at around 25, and you do drop as you get older, but generally not to the point where you're having tons of fractures. Most men don't have tons of fractures in older age, but when women, assigned females, go through menopause, their calcium drops quite rapidly, and osteoporosis becomes more of an issue. So we have to talk about calcium and vitamin D. So boring, because nobody wants to drink milk anymore because it's not good for you. So we spend a lot of time talking about calcium and vitamin D, particularly those of us in Canada. We're north, and we don't get as much sunshine, particularly in Vancouver, so we have to keep everybody up to date. So what are the kinds of things that we monitor? I think, again, kids are generally healthy people, so they don't need as much monitoring as adults do. They're not going to generally get diabetes the next day or heart disease the next day, so we don't have to be quite as on it with the monitoring. There's reasonably good evidence that a lot of the lab monitoring that you would do in an adult is kind of unnecessary in kids. But we do watch their height and their weight. We use growth charts that are the same as the assigned sex, because that is actually more appropriate for how they're going to grow, but we make them all gray. So so that you can't tell because ours are pink and blue, just like in the U.S. Our growth charts have, they're binary, but we just gray them all out so that they all look like this. We do follow blood pressure. Endocrine Society suggests sitting height and Tanner stage. I don't do sitting height because I don't really know why we would do that. And Tanner stage, nobody likes to be examined. I do not examine the kids after the first. Once they go on their blockers, then I stop examining them because they don't like people checking them out. And there's really no reason to. If I know that their hormones are zero, I don't really care what their genitals, how their genitals have changed. About every 6 to 12 months, it is good to know when you're on the blockers that the LH and FSH and the estradiol or testosterone is suppressed. It always is. It's very easy to turn off normal puberty. Endocrine Society suggests 25-hydroxyvitamin D. Yeah, okay. It also suggests that we do bone densitometries, and I have not been doing this because I don't know what to do with these results. I know there are studies that are happening. I know that people do them with an aim to looking at this prospectively, but I think until I know what I'm looking at, I don't know why I would be doing this. I'm optimizing calcium, I'm optimizing vitamin D, but if I got a result, I wouldn't have the first clue what to do with that. I mean, I know how to interpret bone mineral densities in kids otherwise, but I don't do it in the trans youth. So what do? I offer blockers to most of the assigned males. Unless they're already fully pubertal at that point, I would treat them as an adult. If you think about a 16-year-old boy and you think about a 19-year-old young man, there are still a lot of changes that have happened, right? Particularly the bony sort of gorilla kind of stuff. So it's you really have to. We tend to use the blockers until vaginoplasty, which the majority of assigned males choose to do. In assigned females who still are growing breasts or still haven't started their periods, that's a group that we tend to offer the blockers to. The later you are through cisgender female puberty, the less I think that the blockers are really going to help you. And the longer you go through puberty, the more you are going to have problems with having menopause at school. And nobody really wants to be having hot flashes at school. But if you were to take an assigned female who's late in their puberty and put them on blockers, you're going to cause menopause. We will treat older kids if they are super bothered by erections, by their sex drive, by their periods that we can't get rid of any other way. We will use blockers in those people. We always get informed consent. Our consent forms are online. Canada has way different rules about this than the United States. In Canada, in general, any child of any age can consent to any medical treatment, provided they can demonstrate an age-appropriate understanding of the risks and benefits, and that the provider feels that this is in the kid's best interest. That is not how it works in other places. He said, I was born in the United States, just so you know. Okay. For the assigned females that I think are kind of beyond the benefits of Lupron, we would get them menstrual suppression if that's important for them, which it is for many of them. And for the older assigned males, then we would, just as Mashall would, we would use Spiro. Somehow I got assigned 2 slides on fertility preservation. I'm not an expert. In trans girls or assigned males, sperm cryopreservation is relatively straightforward. The idea is abhorrent to many of those kids, but the idea is also reasonable to some kids. It's not super expensive. It's not free. And some kids do choose to do that. The other methods I don't really know anything else about, and I don't think that they're very commonly used, and they cost a lot of money. The options for assigned females are fewer when you're talking about kids. You can put ovaries in the freezer. You can do other sorts of fancy things. It's very, very expensive. It requires a surgical intervention, and it's just not really practically done in most places that, to my knowledge, in youth at this point. SOC8 has now come out, and it just talks about the age for treatment. So previously, I think it said something like the age of 16 is considered the age of majority in many countries. Use this as a guide. That's SOC7. SOC8 says, think about treating kids at age 14. with hormones, unless there are significant reasons not to do that or to do it earlier. Honestly, 13 and a half, 14 is where I think many places feel comfortable to do that. I think you have to think about your community care. I think you have to think about being sued, think about all the other things that you think about. That does not mean that every 14-year-old is ready. That does not mean that every 14-year-old gets treatment just because they're 14. It means that that is an age where most experts feel comfortable that many children have the capacity to consent, assent for treatment, and often parents are happy with that. 14 is well beyond where an assigned female would be in puberty, and it's late for an assigned male, but it's still pretty early compared to where we used to do. This is Endocrine Society guidelines. Every 6 months, you do this many milligrams per meter squared. Even endocrinologists don't like treating people by meter squared. And most of the kids are kind of in the same age group. So what I do is similar. Informed consent, discuss the reproductive options. We tend to use testosterone cypionate because in Canada that's cheaper and it's usually easier to get. But testosterone enanthate is fine. We don't have the other forms as Mashall mentioned. We tend to go about every 6 months, we go up a little bit. So the average sort of 15, 16-year-old kid would get 20 milligrams for 6 months, then 40 for 6 months, then 60 for 6 months, which is often an adult dose or getting close to an adult dose for many youth, and some youth may use up to 80. So we kind of go in that kind of a time frame. If we were to meet a younger kid, we would go slower. A thinner kid, we would go smaller dose. We tend to use subcutaneous doses because it's easier to treat kids. We don't really tell them there's an option. I mean, we do tell them there's an option. They know there's an option, but we usually present subcutaneous as the way to do it. And by the way, almost all kids don't learn to do it themselves, just as kids with diabetes learn to give their own insulin, so that we just start out that way. Now, if you're on testosterone and you're getting close to an adult dose, you can generally stop the blocker, if they're on a blocker, without getting breast growth, which is what the kids don't want. So you present that as an option. If you're on 60, 70 milligrams, an average size kid, generally that's enough to stop the Lupron and see what happens with the breast growth. And some of these kids have no breast growth, and they don't want any breast growth, or they have very minimal breast growth. So you stop and you see what happens, and in general, that works okay. Some of the kids choose not to go up to a full dose, right? They just want to get rid of their periods, or they just want a little bit of a deepened voice. They may want to come off their testosterone. That's generally not going to be, that may not be enough to keep their breasts from regrowing if they come off the Lupron. As far as puberty induction, we in our province, the oral is what's paid for, so that's what they get. And again, micrograms per kilo, that's nice, whatever. But I do it, sorry, I have to go backwards. Anyway, we start with about a half a milligram, 1.5, 2. Now, the kids that are on Lupron don't need as much as the adults do because they were already get their puberty turned off. So we're not giving suppressive doses of estrogen, we're giving physiologic doses of estrogen. If you were going to use a patch, these are suggestions to use a patch, and we do sometimes use patches, but it's not what's covered typically in our province. They're changed twice a week. Not all teenagers like patches. They find them, they're visible, they're itchy. They don't want other kids to see that they've got a patch on. So what I do, because again, this is what we get in our province, informed consent, discuss reproductive options. We use estrase or generic estrase. We try to get the kids to do it sublingually. Nobody has patience to do that, but we do suggest because we think it works a little bit better. And again, half, 1.5, 2, and at some point we get levels and see where we are. Again, we may go slower in a younger kid, we may go faster in an older youth. Not everybody wants a full dose, although I would say the majority of trans feminine kids do want a full dose, at least to grow breasts, and then down the road they may choose otherwise. These are just some standards. This is what looks very much like standard. This is not my slide. This looks like standard 7. As we know, 8 just came out, so it looks a little bit different, but we all know how to find this. There we go. The UCSF Center has great guidelines for adults and for kids. These are not just youth things. These are for everybody. This is a nice article from the New England Journal. on the care of transgender folks. This is primarily the medical care. And first, do no harm. Yes. I think that's it. Oh, doing nothing is harm. Oh, there we go. I think we have time for questions. There we go.
Thank you, Mashall and Dan. So we have time for questions until 10:15. So hopefully we'll be able to answer many, many questions in that time. I would invite you to go up to the mics on each side, and if you have a question. Oh, sorry, go ahead.
On reviewing SOC 8. Good there? Thanks. You'll find actually quite a lot of discussion about estrogen type that isn't in the slides. And the short message is estradiol, 17-beta estradiol, stands for it is the physiologically produced ovary hormone. So bioidentical in that terminology. And that basically the one we use because over many studies for many years, it just seems to have a lower risk of venous thromboembolism in particular. So we're not using the older conjugated estrogens. So conjugated estrogen, CES is one brand name. Premarin was a conjugated estrogen at that time. It stood for pregnant mare's urine. Ew, eh? So we don't use that. And not using birth control pills, which are also synthetic estrogens with a higher venous thromboembolism risk. So that's mostly about that. The other issue was on venous thromboembolism risk, a number of studies that appear to show lower venous thromboembolism risk with transdermal estradiol preparations. So a lot of selection of estradiol type has to do with people's potential venous thromboembolism risk, which means their personal history of venous thromboembolism, so pulmonary embolism, deep venous thrombosis, family history of same, suggesting in first-degree relatives, age over 45, because that's when the baseline risk goes up, tobacco use, diabetes. So I think that's pretty important discussion on estradiol types. And I'll just pause on that. They also have some other comments about blockers used overseas and things, but thanks.
So let's kind of alternate one side to the other. So, great.
Hello. Hi, my name is Amy. I'm a clinical social worker from Toronto, and I work with doing a lot of case management for adult transgender patients. I have quite a few patients who have been on HRT for 10 plus years, and they've been asking about subcutaneous pellets that have only recently become available in Ontario, obviously not through our public health system, through the private system, but is there much research on it? Because many doctors seem hesitant to use them.
Right. So I have no particular experience, too, because it's so new. It's new to our jurisdiction. And people here in the room who've been using them? Yeah.
Okay.
My patients really like them. I have a tendency to use them in people who have a lot of topical reactions, both to the injections, the patches, and as well as the creams.
Okay.
On average, they're like, we have ordered them in the U.S. from one pharmacy in Texas called Alliance.
Okay.
And it takes like 6 to 8 weeks to come in.
Yeah.
They come with a drug cancer. My patients really like them. They're steady. Figuring out the steady state, I'll usually check them at like 2 months, 3 months, 4 months, anywhere from 3 to 6, depending upon the person. You can increase by like 1 pellet each time, depending on what the dosing is, on how they're tolerating it. But my patients really like them on it.
Okay.
It's really quick. I do them in a 30-minute visit. You're just doing a lot of numbing down into that subcutaneous tissue. You feel the pop of the drug cancer going in on it, but all my patients have been really happy with them.
So just one last quick question. Does there have to be a medical indication for them, or could it be for like my clients who just don't want to do a weekly injection after being on it for 10 years?
So the U.S. is very insurance driven. So
Right.
ours is like sometimes have to justify. Some people's insurance just covers it, and they're just like, this is an option. Like you can do a gel or you can do a pellet. But I will offer them, especially if they can get them covered. I always offer them as a once they've tried one other thing to see how they're doing with it. I pretty much always will offer it to them to see. I find the others it's easier to adjust if you get that because the pellets once they're in, you have to
Thank you so much.
Mashall, Dan, any?
Yeah, again, no personal experience. I have people move from other jurisdictions, and I've had some people say, actually, I want to come off them and just use something else. Other people asking, could they use them? For the Canadians in the group, there's a group who do, there's several, you can just Google them up. I've seen them. They're using plant-based, in this case, hormones that are Health Canada approved. So it's kind of like analogous to a compounded situation. Not very mainstream and sort of mainstream pharma yet for those of us in Canada. So yeah, you know, we like to be flexible. What works for people best is what I'm really interested in exploring.
Thank you.
Perfect. So my name is Karina. I'm a pediatrician in Rochester, New York. I have a question that may be a little bit more US based, but you can try and we'll see what happens. They're actually connected. So the first question is, for our yearly annual physicals, we do need to do health appraisals for the school. And part of the health appraisal for sports is a Tanner staging. Do you ever come across, so my two questions are, when do you switch the growth curve from male to female? And then do you ever come across sports or schools that will say, this kid isn't hitting the appropriate pubertal timeline and therefore can't participate in sports?
Trans youth grow much more like their assigned sex than they do their identified gender. There's a 5-inch difference between boys and girls generally, and with starting blockers early and adding hormones, you're only going to correct 1 or 2 inches of that 5-inch difference, up or down. So which is why we use the natal, the growth chart that goes with their assigned sex, because that's really more typically how they're going to grow. But again, it's not perfect either because we're stopping their puberty, starting their puberty. We don't have the same thing here, of course, around, well, I shouldn't say of course, but we don't have the same thing here around that for sports as far as having to give a Tanner stage, because I don't even remember, I trained in the US, but I don't remember that from back a million years
like
ago.
New, it's for safety, so they'll say like you need to be 3, 4, 5
to me,
be
like
varsity or whatever.
everybody playing competitive sports should have a bone age, and then you should go by your bone age, because that's way more fair than, having a 13-year-old and a 13-year-old playing hockey against each other. But that's a different story. No, so can the child decline to be examined?
Yes, usually you have
That's
to have
probably
a
a-
conversation with the athletic director then at
Yeah.
that point.
Yeah.
So, not an issue.
I would just write age appropriate and be done with it.
Thank you.
That's why I practice here and not in the U.S. anymore.
Please.
Hi, I'm Stephanie. I'm a family medicine doctor. I do adult primary care in Washington, D.C. And my question is whether you have any information or studies or a sense for how different or how the gonads would be affected from a fertility perspective if you start puberty blocking at Tanner stage 2 versus later, and how you advise your patients and their parents on making a decision from that perspective.
Yeah, I think that's the hardest part of what I do. Because, of course, this is not what's in the mind of a 13-year-old or 15-year-old or even a 17-year-old, because, babies are icky and they poop and ugh. And, you can just go to a store and adopt later on, right? They're just like there in that story. So kids have zero idea about their fertility, right? So an assigned male has to get to a point in puberty where they're making sperm, at least in today's technology, right? So it's, age 13, 14, 15-ish. So if you're turning puberty off before that, then they go through female puberty. Then they choose to do semen, use their sperm for whatever. They would have to come off their estrogen, go back into male puberty to the point that they're producing sperm, which would be a lot of virilization. Yeah. So that's something we have to talk about. For assigned females who are having periods, when they go on testosterone, we know that there's a very good chance if they come off, and particularly those who are having regular periods, if they go on their testosterone, come off their testosterone, their periods come back relatively quickly, and they can donate an egg or get pregnant, whatever, relatively straightforward. If you were to start,
At Tanner 2, it's not the case.
if you were
though.
to start early in a reproductive age in an assigned female, again, that person would have to come off their testosterone, go through female puberty, probably grow breasts to do that. Now, there might be ways around that as far as stimulation with gonadotropins like what the fertility folks do, but I don't believe that that's like a fixed thing yet. That's easily available and is even slightly affordable. So you can freeze eggs and then later use them, but that's still a very early kind of technology that's quite expensive.
But the eggs that you would freeze at 10 or 2, are they even fertile?
So, you know, a little bit of what we know is from like little girls who get cancer, right? And they try to do whatever they can in a very fast fashion to preserve that girl's fertility for down the road after she's cured from her cancer. I don't think that lots is known about that still.
Yeah.
For say a 10-year-old assigned female, I don't think we know.
And the complexity in the U.S. context is that for a lot of folks, this would not be covered, and so.
Right, oh yeah, no, it's all,
Yeah.
it's all self-pay, exactly,
Yeah.
here as well. Probably, I think in Europe, there are places, maybe people know that's like sort of more part of the healthcare system, but here, that's all would be private,
Okay, thank you.
yeah.
Thank you.
I have 2 questions for you. My name is Danny. I'm a pediatric/adolescent nurse practitioner from Chicago. I use she, her pronouns. My first question is, we see a lot of patients in our clinic due to either access to care or barriers to care who are on blockers that don't get them at their regularly timed intervals, which for us typically is every 3 months. And typically for us, we do labs at the second blocker that are timed labs, 45 minutes to 1 hour after the injection, that we do like an FSH and LH to look for efficacy. But for those folks who are kind of off of the blocker schedule, do you know of any kind of, I wouldn't say contraindication, but like risk benefit to them being kind of off that schedule other than maybe a little bit going through puberty and then being suppressed and that irregular interval? And then my second question is, we've been seeing a little bit lately in Chicago the off-off label of subcutaneous estrogen, and I wondered if you could speak to that.
So, you know, when the kids go on blockers, we warn them, like, if you start and stop, you're going to push your puberty, you know, you're going to keep pushing your puberty forward. I think the 3-month blockers, I think you're probably still good at 4 months, I'm going to guess. But the monthly ones, you know, you're probably not good for a whole lot of extra weeks. So the kids don't want generally more puberty, but you know, the reality is that people with money and life and COVID, you know, that they are off their blocker schedules a little bit. So I mean, it's just going to push the unwanted puberty forward. I've used subcutaneous estradiol in like 3 young adults. It's not licensed in Canada. It's not on the market here. You can get it compounded here, and I think it works great. Have you used it lots?
Yeah, I have a number of people using estradiol valeric compounded subcutaneous with similar serum levels. So not studied in the same way as subcutaneous testosterone is to my knowledge, but anecdotally the blood levels look pretty good.
Thank you.
Thank you.
Hi, I'm she, her. I'm a family doctor and psychiatrist in Pittsburgh, and I do lots of adult gender medicine, looking to get into adolescents, so thank you so much for the basics. I have a patient that I absolutely promised I would ask an expert this question. And I know you guys said that, that progesterone, we don't know, and I know that we don't know. But that, I would say progesterone questions with regards to breast growth are the questions I get by far the most from my patients. They are doing lots of reading online in forums that I don't know much about. And some of them in particular have brought up that timing of when you start progesterone after estrogen therapy can really affect the shape of breast growth, and I'm not sure if there's data for that. I couldn't find any papers, but I promised them that I would ask this question.
Great. So happy to talk about progesterone. So extremely important ovarian hormone. Actually quite a focus in Vancouver, where we have a researcher who's made her whole life in progesterone research, in the 90s at the gender clinic at that time, did a randomized prospective placebo-controlled trial of oral micronized progesterone and looked particularly at breast development. In that trial, small trial, not a lot of power, the main effect was on areolar and nipple development, and found a positive effect. I mean, that's a good standard trial. Wrote an opinion piece in Endocrine Society a couple of years ago about why she felt progesterone is important for transgender women. Mostly, it's mostly physiologically based. And again, for SOC8, when there is a systematic review, looking at exactly the questions that your client has, they didn't have enough evidence to be able to make a comment on it. Pubertal breast development, progesterone does have a role. It's has to do with like the type 2 lobules, which has a lot to do with breast volume as well. So there's some physiologic plausibility to that, and I think cisgender women breast development usually will have some estradiol first and progesterone following, and it's hard to know somewhere in that first year or so. So long discussion, it's clinical controversy, that's why it's there, lots of discussion in the population about it. And where I see SOC8 came, they just said, well, we don't really have evidence. If you're going to have it, have a discussion. I think it's a relatively low-risk intervention with some physiologic plausibility based on both this small randomized controlled trial on areolar nipple development and also on how pubertal breast development takes place. Again, on expectation management, breasts are difficult, so it's there. I think the other thing that it's good for is if you're counting on an ovarian hormone to feed back to the hypothalamus and pituitary to suppress gonadotrophins, it's another feedback, right? It's another thing. So I've had people on fairly good-looking estradiol dose whose testosterone is not down in the range there, not on blockers, just the addition of progesterone dropped the testosterone to that target range. So there's a physiologic basis. When you think about it, again, our whole field's off-label, and we all evolved, doing on the basis of physiologic plausibility, over a bunch of years. It would be a super interesting thought experiment to say, let's suppose no one had ever done gender-affirming care before. How would you design the studies? What hormones would you use? What blocker would you choose? Again, if you have enough ovarian hormones, you don't have any testosterone to block, how often would you use them? Things like that. So, but that isn't the way the world works. So anyway, kind of a long discussion. That's sort of where I come down on the progesterone question. I hope it's of some benefit for your client.
I will relay it to them.
Thanks.
Thank you.
When girls go through puberty, they make estrogen for the first couple of years, and then when they start cycling is when they make the progesterone. And progesterone is cyclic. There's not lots of progesterone between cycles, right? Not
Yeah.
tons. And nobody knows what progesterone does in guys. That's a different issue. So I've had patients who want to take it monthly to feel like they're cycling and PMSing or whatever they want, however they want to do that, and
All
that
right.
seems to work from the mom's points of view.
Okay.
But
Now that's authentic. Eh?
yeah. I think
thank you.
people would suggest if you're going to use progesterone to use the micronized
Micronized progesterone.
and not medroxyprogesterone.
Yeah.
Yeah, and that's exactly what we do in non-trans girls who are not going through puberty for because
Right.
they've had chemo or whatever. We start with estrogen, and after a couple of years, we add cyclic progesterone.
Okay.
Yeah.
Thank you so much.
Hi, my name is Sarah. I'm a mental health counselor in New Hampshire. I can't believe you just made that comment because my question is about periods in trans women and the monthly cycles. And I have a couple of clients that seem to have regular cramping and discomfort, and just wondering what.
In trans women and trans girls. Well, that's interesting. Are they on progesterone?
Yeah, mood fluctuations and cramps cyclically.
I have no physiologic explanation for that.
Cool. Okay.
They're teenagers. That's my physiologic explanation.
Awesome.
They're
I love it.
teenagers.
Thank you. Okay.
Hi, I'm Antoine. I'm a family doctor from around here, just an hour up north of here. And my question was, I have a client that has started testosterone, loving the effects, except she's an assigned female at birth, and she doesn't want to go full transition. She wants to do the non-binary, and now she is having a
Yep. Lower
augmentation of the volume of the clitoris. Thank you very much. And she doesn't like that quite as much, and she was wondering, was there a way to mitigate those effects, essentially having her cake and eating it too?
Yeah, that's right. So really try hard to understand people's goals initially and kind of have to have a discussion. You can't always pick and choose because it's in the bloodstream going to things and tissues respond. So there would be no clitoris-specific approach to pharmacotherapy that would shield that tissue from the effects of the testosterone other than adjustment in dose. And also what's taken place will probably remain. So again, there's folks who just want to move a certain way along the androgyny scale. And then I'll use the SI units. If 8 to 28 is the male range, and under 1.8 is the cis female range. I've got a number of folks who say, I like 3, thank you very much, and I'm happy here for the rest of things. So they get some of the effects they want, none of the others. So I think the only discussion about expectations, but also an offer to try dose titration and see what happens might be worth considering.
Thank you very much.
Thank you.
This actually wasn't my question, but going off of what he said, I have a number of people who online are saying like the finasteride, dutasteride is like potentially something that could decrease how much bottom growth you get, and I didn't know if there's actually anything real behind all of that.
I think, so that again, now we're talking about, can you kind of do some tissue-specific effects of testosterone? There are a little bit of data, it's not very strong, it's more lab-based, about low-dose finasteride perhaps antagonizing the effects of, so it's really testosterone to dihydrotestosterone conversion going to receptor at male-sensitive hair. So it's common for folks in that situation to try, I'm talking like a milligram of finasteride orally, hoping to target particularly scalp hair, while still allowing testosterone effects to take place in other tissues. It's not official, another area of clinical controversy. I think that is the dose that's used. Dutasteride blocks is an androgen receptor blocker as well in the same family. There's a type of an enzyme is called an isozyme. Finasteride blocks 1, dutasteride blocks like 3 isozymes, so it's actually a more potent androgen receptor blocker than finasteride. And I know of no literature that suggests any selectivity. It's probably more potent in, say, cisgender men on prostate, and it could occasionally be used on hair, I suppose. So I'm on this very shaky biological or laboratory grounds, I would be more inclined towards finasteride than dutasteride for hair-specific things at a low dose. But, there's lots of discussion out there. There's a whole web full of people looking at, obscure lab papers. That's where the discussion comes from. Right now I'm offering finasteride at low dose for hair-specific things and on shaky evidence base, but better than nothing. And people seem anyways to be happy that they're not losing their other androgenizing effects on it at that dose.
Gotcha. Okay, so I'm Gabby. I'm a adult primary care physician out of Baltimore, Maryland. And my question was actually about testosterone. I have a number of patients who say that they want to have like the most voice lowering that they can, and that they've heard that being on low dose T for a longer period of time does that. But I'm also generally up against they need to have the menses stopped. So I don't know if the voice deepening thing on a low dose is real or not. I usually tell them I haven't noticed it, versus like just going up and getting a high enough dose just to suppress the menses. So I didn't know if you could speak to
I
that.
can't say that I've noticed a difference in people who are on long-term low-dose testosterone ultimately for voice versus those who tend to accelerate from low to sort of full virilizing doses. I've not observed it. Thank you for bringing it up. I'll start. You can honestly learn so much by just hearing a question like that, and your antennae go up and you start paying attention to the folks in your practice. So it's always hard to know in this whole discussion what's there, what's physiologic, what isn't, what's urban medical legend, and I try to be humble about this because often people I'm learning from may have picked up on something I haven't. So I have not seen it as an effect personally, but I'll start thinking about it. Thanks.
Yeah, they call it like microdosing a lot. You hear that term
Yeah, a lot
thrown
of
around?
I have a number of folks what I would call microdosing, and it just they're happy with where they are. They haven't specifically taken voice as the reason for that. It's actually been a number of other things. But adding voice into this mixture is a pretty interesting thing to hear. Thank you.
Yeah, if you think about how we do it for kids, we start with 20 milligrams, and I would say 2/3, 3/4 of the guys lose their periods on 20 milligrams a week, and they get the voice changes that their guy peers in their class are having. So, giving the bigger doses that adults get, I don't know if that changes their voice differently.
I'm hearing voice changes on 25 milligrams
Yeah.
only of testosterone
Yeah.
injected weekly by 3 months in just virtually everybody.
Yep.
You know, and some folks remarkably so, and it goes up after that.
And most of them will become amenorrheic at that point. Many.
Yeah, it depends on their body weight.
Yeah.
Great, thank you.
Hi, I'm Kathleen. I'm a psychologist, and I work with a lot of providers who do hormone therapy, and I'm like the pride psychologist for the clinic. So I get a lot of questions from providers about the contraindication that you mentioned, which was very vague, about psychiatric complications for initiating hormone therapy. And so like, what do you think about this patient considering that? So I guess my question is there more specific ideas about what sorts of psychiatric indications might be a contraindication when a lot of the literature shows that depression, anxiety, suicidal ideation improve with hormone therapy? What might be a contraindication? I hear a lot about psychosis and estrogen, so if you can specifically speak to that and to anything else that might be more than just this person's really unstable, is it a good or bad idea to start, or more data or resources where I could go?
I don't think, so my personal opinion is that this is not a thing for either hormone. I think I would probably frame it, are they mentally stable to go for wisdom tooth extraction? Right now, like
No,
an
that's very
elective-
helpful, the idea of-
an elective
right.
surgery thing, or something where they can both give consent, could cope with an unexpected event that took place on it, responsible enough to do with it.
It's
So
about
I'm
capacity
actually
and
more about it.
self-management.
Yeah,
I
this is
can
just
assess for that.
Yeah, I think that's where I'd frame that. I don't think it's a hormone thing. Again, most people get happier, which is why we're doing that, which tends to be helpful for mental health.
That is extremely helpful. I will be quoting you.
Good, got it.
I have had a few kids with schizophrenia who do notice that if they push their testosterone too much, that it seems to them that it makes things a little bit worse. So the patients with schizophrenia are doing well on their meds, and so they will sometimes moderate their dose a little bit just to keep the voices down or whatever their bad symptom is. I think for kids, exactly what Mashall said, but I think if they have a florid eating disorder, or they have suicidality where they're in the hospital every 2 weeks, I think sure the testosterone or the estrogen might make things better, but I think it'll cloud the picture. And I think if things get worse, like if things get worse, is it just a suicide? I just tell it to getting worse, but then everybody's gonna be like, oh my God, you started the testosterone. That's why they're bad now. So I think. And to be perfectly honest, kids sometimes won't look after the stuff they don't want to look after. They only want the stuff they want. And you'll get a kid with an eating disorder that's never going to address the eating disorder until they're sort of pushed to do it. Like, we will work together with the eating disorder team. We will do this, but we are very mindful of the fact that if things get worse, we might have to delay, postpone, reduce a dose, not push the dose forward, something like that, just to a little bit to keep the kids on track. And that sounds mean, but just from experience, some kids will just never address the bad stuff and only just clamor for the hormones. And I think you got to balance that a little bit. Many adults too. Yeah, I think adults as well, right? But I think with kids, we have the parents behind us.
I only want the things I want.
Yeah.
We have 15 more minutes for questions. Yeah. Your side, yes, sorry.
My name is Lucy. I'm a family doctor in Minnesota. I have a patient who he has a lot of uterine irritability, and now he's starting to spot. And so we talked about an IUD, not comfortable with that, no thanks. What do you typically use in a patient like this? Do you have any suggestions? Because obviously anything feminizing is very distressing sounding to him, and so progesterone I've thought about or even offered, but didn't feel like I had enough evidence for something like Depo-Provera, where I feel like there's maybe not as many feminizing effects. What do you use in a situation like that?
So adult patient?
Adult, yep.
Yeah.
20.
Yeah, it's tough. You know, the vast majority of people, I'm going to say mid 90%, on if their goal is to have fairly full virilization and use fairly full testosterone doses, are probably running a level in the upper third of the reference interval on a sample done midway between injections, and I'd say 95% of them no hormone-related periods. So for the remainder who are having spotting or bleeding with some dysphoria, several questions. One obviously is just simply a gynecologic question. Is there anything else going on there? Is a gynecologic exam being done? Are we missing anything that's not hormone related? And then for the remainder of people, there are some periods that just seem really stubborn, so that's a tough call. So then we're having a discussion about options. You mentioned some already, which is intrauterine device. The other, most people I think are fairly rejecting of using ovarian hormones for suppression, feeling that they were trying to move away from that. There are some folks in whom this is their personal line indication for gynecologic surgery, so hysterectomy plus or minus oophorectomy. That's the thing. If we want to go really off-label, there, you know, for cisgender men, our estradiol is made by conversion of testosterone to estradiol by aromatization, and there are aromatization blockers. So anastrozole is one of them. It's used in the bodybuilding community to block breast growth. It is effective. Some of it happens in fat tissue, and some of the transgender men I've seen who are on the heavier side in this situation, they have had fairly elevated estradiol levels. We've gone through the options. I've trialed aromatization blocker, anastrozole with success for this indication. It's another drug, so I think there's some individualization there. So usually my algorithm would be, if I got a lot of testosterone present, are there any other gynecologic reasons going on? If you don't want ovarian hormones, are you in a position where gynecologic surgery would be welcome? And then really off-label in a few cases, this aromatization blocker.
Yeah, that's interesting. I had a cisgender male that was a doctor and put himself on anastrozole because he didn't want to take testosterone. And I had never heard of it. I was like, okay.
Yeah.
So I get, that makes sense. Thank you.
Out there. Yeah, that's what I'm saying, gynecologic
Right.
exam.
So
yeah.
I got him, that again, this whole idea of a pelvic ultrasound, very uncomfortable. So I got him to agree to like a pelvic ultrasound without the transvaginal, but he has not done it yet. So I don't know.
Stay tuned.
Stay tuned.
Thank you.
Okay. Yeah, I should say my algorithm is actually at that point punt to gynecologist who's experienced in the area. So.
That seems to be the algorithm that our institution too.
Yeah.
Thank you.
Hi, I'm Kristen. I'm a social worker at the gender program at our children's hospital in Chicago. And so I do ongoing treatment, but I also do the readiness process. And so I have some non-binary patients who are just not quite sure what they want to do as far as hormones or no hormones, and they're on blockers. And so you mentioned doing lower doses of testosterone and estrogen. I'm wondering what effects might they see from lower doses and what wouldn't they see from lower doses? Or do you have any other general guidance for them as far as?
So whenever I'm starting a kid on T, I'm sure you do the same. I'm like, I don't have a set, you know, you can't have more than the lumberjack, but you don't have to be the lumberjack, right? So you know, you might, we're gonna start here. We're gonna work our way up if you feel like it, but at every single point you wanna start, you know, hold at that dose, that's great. But hormones are, you know, kids can be non-binary, but hormones are binary, as we've heard. They're gonna do what they're gonna do, and some people are gonna, you know, grow a beard faster, some people are gonna grow genital tissue faster, some people are gonna have their voice drop more quickly. So I just, some kids want to start really slow to see, because they're not really sure how they're going to feel with it. Some kids are like, woo, and some kids are like, no, okay, that was good, but I'm going to stop now. Some kids just want the voice changed, right? So they just do it till their voice changes, and they get a bit of an Adam's apple. Then they deal with their periods until they can have a hysterectomy or whatever else they may want down the road, or upper surgery or something. But I think if you take testosterone long enough, you're going to get changes. Maybe not that of a cisgender man, but you're going to, eventually it'll accumulate to the point you're going to get a fair number of changes. So I just tell the kids we can go as slow as they want or as fast as I'm willing to put up with. Yeah. As fast as normal puberty.
Yeah, just tell people we're responsive to your needs. As long as we can do this medically safely, we can twist this dial a lot or a little bit. And also, sometimes I find people get started and they go, I'm great. And the people go, oh boy, do I like this. Let's give me more. And I say, we can adjust. I just commit to listening to you about where your needs are now as opposed to where they might have been before.
Thank you.
I think the other thing about kids is, they haven't even had biology in school yet. Many of them, right? So, for them, hormones is just up here. They don't understand, a hormone does this and does this. And so, some of the kids are very well read, but a lot of them are pretty naive as far as how biology works. So I think you have to explain, you're going to change your voice, but also you're going to probably get a little bit of hair on your face or some growth down below. So I think you have to, also just be pretty basic for some of the kids because they're 13 or 14, whatever. Yeah.
Great. So we have 5 minutes left for questions. If your questions aren't answered for people in line or other people, please come up
Yeah, we're here.
at
Please.
the break. Okay? Please.
Hi, I'm Rebecca. My pronouns are she and her. I am a nurse practitioner from Philadelphia and mostly working with 13 to 25-year-olds, so fun age. I've been hearing more and more about brain fog with Spiro and a lot of my patients wanting to stop it. And it does seem like stopping it has been beneficial. So I'm interested about that. And then there's another rumor, because the young people love the rumors, that Spiro is also keeping them from getting the breast growth that they're looking for. And so I find more and more new patients are coming, and I'm having really long conversations about Spiro. And so I'm just wondering if you guys see this in your practice, and then how do you have that conversation, because again, there's not a lot of
Great. So this is an
research.
androgen blockade discussion. And, things evolve the way they do in medicine just because of the way it was. So we're in the 1990s. There's an aldosterone's a hormone that has to do with our blood pressure, sodium, potassium. There's an aldosterone receptor blocker. It's probably there. It's spironolactone. And people notice these cisgender men are growing breasts when they take it. They're not taking any estradiol. So it does grow breasts. It wasn't really holding people back. In that case, we're now using it for therapeutic gynecomastia, as it were, and that's how that evolved. It's pretty safe. It's used in a number of settings for decades and used for people with fairly serious heart trouble, people with fairly serious liver trouble, used in polycystic ovary syndrome for anti-androgenic effects for a long time. I never heard about brain fog until about 3 years ago. It just appeared, okay? So is that urban medical legend, or is it that somebody actually noticed something? So start paying attention. So what I say now to folks who are discussing, because there's a number of androgen receptor blockades. This is not a custom-designed androgen receptor blocker. It does something else with a knockoff effect on androgens, as opposed to the custom androgen receptor blockers used in prostate cancer. So I'd say if I look at folks, I'd say, about 95% of people, they got no problem with spironolactone, right? They're fine. They haven't noticed anything. When I hear brain fog, it's like, you have ADHD. You actually told me you had brain fog before we started. And actually, a lot of the folks I'm hearing about brain fog, it's like, have you considered the possibility of ADHD? And actually, a lot of them actually do. So is it all ADHD, or does it make brain fog worse than ADHD? The discussion does appear, I see last night reading SOC8 in there, so it's tagged as a possible side effect. I'm respectful of it because ultimately people are pretty dysphoric if they think they're taking something that's not good for them. I think I confidently say that it's not, I don't believe it holds people back in their breast growth. If brain fog's an issue, then you're thinking about alternatives. You're thinking about sufficient ovarian hormone to allow basically estradiol monotherapy or perhaps estrogen and progesterone together to suppress testosterone. If you got no testosterone, you got nothing to block, you know. So it may be that you're able to diminish or stop it if the ovarian hormones reach a level. And then the rest of the discussion becomes about other androgen receptor blockade. Now, no discussion has taken place here about cyproterone. It's not available in the US. It's available, it has been the second line in Canada, first line in much of Europe from years. Anybody here with cyproterone users, so outside of the United States? There's actually a pretty long discussion in the SOC8 about cyproterone for folks. It used to just be the go-to second choice drug. However, life's complicated, and there's a big discussion in SOC8 about pointing out some of the effects of cyproterone. A modest effect in prolactin increase. It's probably not clinically significant, needs to be monitored. But there's now this signal about increased meningioma risk at doses of over 10 milligrams, which is kind of where we're at, and I think people are reconsidering it as second line. So for the places and jurisdictions where that was the blocker, there's discussions about that. Finally, there was one slide, and there's very little discussion about androgen receptor blockade with biglutide. A reason for that, it was a prostate cancer drug available in the US where no cyproterone was available, and no data about it. I do think if you were starting today and designing therapy, you'd have a serious look at custom designed androgen blockers like biglutide in a controlled sort of trial, and I think it probably deserves a look. The risks for liver, which are quoted on the slide, if you actually look at the numbers, I was checking again, abnormal liver enzyme tests are less than 1%. Serious liver trouble is much, it's like 3 less than 1%, so you're in the 1 to 10,000 range perhaps. So it probably has a better safety profile. Nobody knows, some folks are talking about it, that's where it comes from. So that's a really long answer to that blockade, but it's something you just have to be ready to discuss because it's out there. And what I commit to do is is try spironolactone, cheap, effective, most people are fine. You don't like it, then we can talk about some of these alternatives.
And do you pull people off of it if their T's been suppressed for a while, like if they are having that concern? Is there a discussion of
do you stop it if their testosterone suppressed? Because a lot of the expressions there, depends where they're at. Some folks are like, I just want to get off this. Absolutely, let's just do it, we'll remeasure. Other folks are like, well, I'm not sure, let's cut it down, measure each month, and just see if we can gradually reduce it. So it depends a bit on the situation.
There are like millions of women, cisgender women, who take it for PCO, and the brain fog thing you would think might have come up already with that.
So I'd like to thank Dr. Dahl and Dr. Metzger, and I'd like to invite the people that have questions to come around this way, and the rest of the audience, if you have questions, please come up, and please enjoy the break until 10:30, and then we're going to have Dr. Longani from GRS Montreal doing a talk on surgery. Thank you.